Okay, so imagine this scene. A patient, just out of open-heart surgery, is wheeled into the intensive care unit. They're completely sedated, they've got a breathing tube in, they can't talk, can't move, can't tell you a single thing about what's going on. Their life is quite literally in the hands of the ICU team.
Now, this might sound a little dramatic, but it's a very real question. You see, the patient made it through the surgery, but the most dangerous part of their journey might be just beginning. And the key to their survival? It's all in a conversation, that critical handoff of information from the anesthesiologist who's been by their side for hours to the ICU doctor who's meeting them for the very first time.
So where do you even start? Well, you start with the past. Normally, a doctor would just ask the patient, "Hey, what's your medical history?" But our patient is silent. That's why the handover has to uncover their secret history, all the baseline conditions they were living with long before they ever saw the inside of an operating room.
And let me be clear, this is so much more than just ticking a few boxes on a form. A seemingly tiny detail, a medication they take, a condition they've had for years, that can be the one single clue that stops a complete disaster in its tracks. If you miss it, if it doesn't get passed along, you could send the entire ICU team down a dangerously wrong path. Let's make this real. Let's say a patient has epilepsy. If the anesthesiologist tells the ICU team about it and the patient starts seizing, well, the team knows exactly what's up. It's medication withdrawal. Simple fix. But what if that little fact gets lost in the shuffle? The team sees a seizure and immediately thinks the worst, a stroke during surgery. Suddenly they're ordering emergency brain scans, starting all the wrong drugs, and wasting precious time, all because of one missing piece of the puzzle. So, what's on this absolutely critical checklist? Well, you need to know about any chronic conditions. Things like hypothyroidism. Miss one dose of that medication and the patient could slip into a coma. Or what about a previous stroke? You have to know if that weakness in their left arm is a brand new 5-alarm fire or if it's just their normal. And then you've got their baseline heart rhythm and oxygen levels. These aren't just numbers, they're the map. They're the reference point for everything that happens from this moment on.
Okay, so once we know who the patient was, we need to understand what just happened to them. We're shifting from their history to the operating room itself. Specifically, we're zooming in on that wild period of time when their heart was actually stopped and a machine was doing all the breathing and pumping for them.
Two numbers become everything here: bypass time and cross-clamp time. Now, don't worry about the jargon. All this really means is, how long was the patient hooked up to that heart-lung machine? And it matters a ton, because the longer the body is on that artificial support, the higher the risk for all sorts of nasty complications: brain injury, kidney failure, you name it. In this game, time is absolutely the enemy.
And you can see that relationship so clearly here. A short time on the machine and the patient's risk is pretty low. But as that time stretches out, man, the risk of something bad happening just skyrockets. For the ICU doctor, hearing this number is like getting a weather forecast. Are we expecting a smooth ride, or do we need to brace for a storm?
Next up, something that sounds simple but is totally vital: fluid balance. It's just basic math. You take all the fluids that went in, the IV fluids, the blood, all of it, and you subtract the fluids that came out, which is mostly urine. The result tells you if the patient's tank is overflowing with fluid or if they're actually running a bit dry, which can often happen. This single number guides so many decisions in those first few critical hours. And then we've got this magic number, the last activated clotting time, or ACT. See, during surgery, they give the patient heparin to make their blood really thin so it doesn't clot in the machine. But afterwards, you have to reverse that perfectly. It is a critical tightrope walk. You've got to land in this tiny window between 100 and 120. If the number's too high, they could bleed out. If it's too low, they could form a deadly clot. It has to be just right.
All right, we're at the last major piece of the puzzle, and it's all about the medications. The patient arrives in the ICU on this cocktail of really powerful, life-sustaining drugs called inotropes. But here's the thing. Just knowing what drugs they're on isn't nearly enough. The most important question, the one that unlocks the whole story, is why. Why were they started in the first place? Each of these drugs tells the story. Is that adrenaline just a tiny dose to help a slightly stunned heart wake up? Or is it cranked to the max because the heart is failing? Was Dobitrex started for a slow heart rate or to help a weak right ventricle? Because those two problems require completely different treatments. And if you see a patient on Primacor, that is a huge red flag that you're dealing with a very, very sick heart. The why is everything. So, when you put all of this together, the patient's secret past, the story of their surgical journey, and the why behind their medications, what you end up with is an absolutely indispensable tool. It's a simple checklist that creates a solid bridge from the operating room to the ICU.
And here it is, the whole shebang, the 8 points that save lives. You start with their history and their baseline condition. You move to the critical numbers from surgery itself, like bypass time and fluid balance, and you finish by understanding exactly what life support drugs are running and, most importantly, why. This right here, this is the complete story of our silent patient.
Because really, in the end, that's what this is all about, isn't it? This handover isn't just some clinical update. It's not just swapping data. It's a profound moment. It is the formal transfer of responsibility for a human being's life from one expert team to another. When you get it right, it's seamless. But when you get it wrong, well, the consequences can be just devastating.
You know, it really makes you think. Step outside the hospital for a second. Where else in our lives, at work, with our families, does taking just a few minutes to have a simple, structured conversation hold the power to prevent an absolute disaster? It's a powerful lesson, I think, about how clear communication can literally be a matter of life and death.